Well, thank you for that kind introduction. Thank you for the organizers for inviting me, and thank you all for being here this morning. I'm going to spend a little bit of time taking what we've heard today so far to the next level, and that is shifting from individuals to populations to change eating behaviors. And as I start that, I want to kind of give you a little bit more background on me. This is my short form of it. I started off as a clinical psychologist, so I know a lot about learning, I know a lot about behavior change, and have spent my graduate career and my full professional career thinking about behavior change several times a week, at least, if not every day. When I left my clinical psychology program, I wound up in a postdoctoral program at the University of Pittsburgh at the School of Public Health. One of the first classes I walked into there was a class on nutritional epidemiology. And after about 20 minutes of my first class in nutritional epidemiology, the thought went through my head in bold headlines: these people need help. Seriously need help. Because at that point in time, nutritional epidemiologists were beginning to figure out things like fats and sodium and calories and their relationship to different types of chronic diseases, but had very little idea about how to go about changing those things. And listening to them talk about it in a class for a semester convinced me that if there was one thing I could do, it would probably be to help people understand how to change nutrition behaviors. After that postdoc, I wound up as my first position being the intervention director at Brown University for the Pawtucket Heart Health Program, which is the symbol on the left. Some of you may recognize that as one of the first community-based heart disease prevention trials in the world to look at how do we do population-based behavior change, population-based change risk factor reduction, population-based change reductions in CVD morbidity and mortality. Our cohort at that point in time was the North Korea Project, Stanford, and Minnesota. So we were really exploring what it was to try and change community behaviors. And then when I took that position and left Pittsburgh, one of the things I spent some time thinking about was how do you scale up individual change programs for obesity management or changing eating behaviors, smoking, and other risk factors? How do I scale up this idea of group-based programs for change, which is what, as a behavioral psychologist, most of us were trained how to think. Change individuals in individual sessions, bring people together with similar interests into groups, and have at them. And I had a huge bag of tricks to get people to change behaviors, a huge bag of tricks. But when you go into a community, what they had already discovered at Pawtucket was trying to lure people into group-based programs for behavior change was doomed to fail. Trying to get everybody to do individual counseling sessions when you're talking about 85,000 people was doomed to fail. And what I started thinking about, well, if marketers can figure out how to sell behaviors, they call them products, to all these millions of people, there must be something in marketing that I could take to Pawtucket. And I began developing what is now known around the world as social marketing, which I'll explain a little bit later in the talk. But after Pawtucket, I was working with the NCI and was the architect for the mass media campaign for 5 a Day for Better Health, that some of you may know, the original campaign by the National Cancer Institute. Spent several years with the U.S. Department of Agriculture, developing their team nutrition program, which was the school lunch program back in the late 1990s. I've done dozens of projects with the Centers for Disease Control and Prevention around nutrition, physical activity issues. Some of you may remember the National Heart, Lung, and Blood Institute used to have a national high blood pressure education program that focused on sodium reduction and cholesterol education. Thank you. And also a lot of programs with WIC and SNAP. So I have been around the bases on nutrition education for the last 20 plus years, along with other kinds of behavior problems. And this is basically what the research and what my experience has taught me. The first one is what I call the micro-macro problem. A lot of people who sit around in rooms like this talk about how do we change individual behavior. And what they think about that is if we can get every individual to change their behavior, we will change the behavior of the population in our community, the population in our state, the population in our country. And that is absolutely wrong. Okay. What we know about the micro-macro problem is that to achieve macro changes involves more than simply the micro actions of individuals. This is called systems theory, and it's called the concept of emergence. That as we start moving up the scale from individual population health to neighborhoods and communities, institutions, and social and economic policy change, different kinds of behaviors, different kinds of causal pathways become involved in those changes. And what's useful down here for the individual is not going to help us understand social relationships, living conditions that we were just hearing about, neighborhoods and communities that we were just hearing about, if you bring an individual behavior change lens to that problem. Okay? So one thing we've learned over the years is that social change programs need to consider more than one scale of reality at a time. You can't simply think about individual behavior change without thinking about social networks, without thinking communities, without thinking about policies. Because in a systems or interlinked world, all those things work together. You cannot tease out which one is the most important one. I'll show you some data on that later as well. And when we think about population-based behavior change, one of the most useful theories that I have found over the years has been this idea of diffusion of innovations. Tens of thousands, if not hundreds of thousands of studies that have looked at the diffusion of innovations, everything from seeds that farmers use to technology to eating behaviors. And what we know is that if you want to increase the proportion of people on this yellow line who are engaging in a healthy behavior or improving their healthy eating index, as an example, you need to think about the population as a normal distribution of people who are classified usually as innovators. There's 13.5% of early adopters. There's 34% of the early majority, about an equal number, 34% of what's usually called the late majority, and there's 16% of what some people call laggards. I call them traditionalists. But the idea is that in the population of people, regardless if it's in the US or any other country in the world, when it comes to innovations, you will usually find these 5 segments of people. And segments is a key word here. Because when you're doing population-based behavior change and not individual behavior change, you need to remember that all people are not created equal when it comes to adopting new behaviors. All right? So trying to come up with the one persuasive messages that will convince everybody to do something differently, again, are doomed to fail. And why is that? It's because what we also know is that these 5 segments of people have very different characteristics. And it's important to understand how these characteristics operate with these people in order to design comprehensive programs that get population-based behavior change and not simply individual behavior change, or worst of all, don't have any effect at all. The innovators is an interesting category of people. My word of advice to you is don't worry about them. You don't need to worry about innovators. They take care of themselves. The second group of people, however, gets to be very important, and that's these early adopters. Notice that across in purple, the one word to remember about early adopters is this idea of respect. They're the opinion leaders in another vocabulary. They're also well-connected socially and locally. They have the resources and the risk tolerance to try new things. Now think about that word risk tolerance. And also, given what we've just been hearing this morning, think about the word resources to try new things. And finally, there's self-conscious experimenters. They go out deliberately trying to do something different. They're the ones going to the restaurants and trying the latest, greatest craze or new food or new chef. And they are watched by other people and they know they're being watched by other people. Early majority is a really key group of people to get focused on in programs. But again, if you remember from the last slide, that's only about 13.5% of the population. And I want you to look at this diffusion slide again, and notice that around here is where you start seeing this accelerating curve, which again is characteristic of all innovations, is that when the population, when your new behavior begins to pick up speed in your population, it's in this early majority category is where that happens. Some of you may remember Malcolm Gladwell and the tipping point. There's the tipping point, okay? Unfortunately, Malcolm didn't understand diffusion that well, enough to explain it and make some good stories. But this is where I always focus my program, is how do I get the tipping point happening? Again, I don't worry about innovators. The early adopters, if you just put it in front of them, more than less are going to try something different, try something new. But when you get up to 20, 25% of the population, this is where programs either take off or they fade out, what we often call the fad curve. And if you can't get the new behavior to stick, the early majority, you're in big problems. So this early majority, notice the first word there is deliberate. These are not people who are going to be persuaded or emotionally cajoled into trying something different. They have a very local perspective. They're very engaged in peer networks. Many of those peer networks involve early adopters. They rely on personal familiarity with the behavior before they will try it. And the question they're always asking is, how does this help me? Again, a key question to keep in mind as you think about how do you talk to people about adopting new eating behaviors. After the early majority is your late majority. Keyword there is skeptical. They're sensitive to peer pressure and norms. So when you hear people talk about social norms and we need to change social norms, you got to remember, well, we're talking about trying to get people in the late majority to adopt new behaviors. Have we, in fact, already got the early adopters and the early majority on board? Because if we don't have them on board, programs aimed up here are not going to be successful because they're not building on what's a naturally accelerating curve. So you simply can't jump ahead and try changing social norms as a way of dragging all these people in the early majority phase along with you. They're cautious. They usually have scarce resources. They want to minimize the uncertainty of outcomes, and they want to see the proof locally. That is, they want to see people like themselves, people who they can see, hear, and touch, doing these new behaviors before they're even going to try them. And finally, there are the traditionalists, the tried and true, the keepers of the wisdom, usually near isolates in social networks, very difficult people to connect with, and they don't connect a lot with other people. Suspicious of innovation and change agents, and they have to be absolutely guaranteed that adoption will not fail. So again, those are usually the last people to get on board with nutrition behaviors. To translate that into another language, if you're thinking about how did people stop smoking, a lot of people didn't, but people who were smokers and saw the Surgeon General's report in 1964, what do you think the reaction for them was? They quit. And what we've seen in the worlds of tobacco and other issues is that the same curve happens. We're at about 14% of the population still adult population still smoking cigarettes. It's a very tough nut to crack at that point in time because of these kinds of features. They're very suspicious of these things. If you get to the point with nutrition behaviors where you have 84% of the population practicing healthy eating behaviors, call it a win. Don't wait till 100, is the moral there. Now again, we take a very consumer-based focus when we're thinking about campaigns. We're not trying to get people to understand scientific messages and scientific research. We're trying to get people to resonate with our communications and with our marketing programs and help them get answers to these 5 questions. How is this better than what I currently do? If I'm currently eating like this, why is changing this food, why is changing these behaviors going to be more successful? How relevant are these behaviors to the way I go about my everyday life? Is it simple enough for me to do? Can I try it first before committing completely to it? And can I watch others and see what happens to them when they do it? These are the questions that time and time again come up from consumers when we start asking them about adopting new behaviors. It's not about the strength of the research evidence, all right? It is very basic stuff about how is this behavior relevant to my life. And these are the questions when you're designing population-based campaigns for change, are the programs that you want, or the questions that you need to address. Now, as I mentioned, there's that tipping point. And another way of thinking about that tipping point is what's been called the innovation chasm, which I think is a great visual for thinking about why do our programs not succeed? Why don't people get the dietary guidelines? Why isn't everybody doing that? And the answer is because you don't use the right marketing techniques to bridge the chasm. You get maybe 15, 16, 17% of the population who say they understand them and use them. But when it gets up here to this early majority, that 34%, you start losing people very quickly. And this is the key trick to designing effective population-based programs. Is not just throwing out the mass media messages that everything is good and you need to try this and you need to feel like this to, in order to eat better. You need to think about how do we connect the early majority with the early adopters so that they can start learning from each other. Now again, how do you connect these groups of people with something a lot of people in behavior change don't think a lot about? Because individual behavior change does not talk about somebody else. Individual behavior change just happens right here. So if you look at sociology, if you look at social psychology, if you look outside the world of the individual psychology, if you look to the world of community change, you have to start thinking about the fact that people live in relationship to other people. For those of you who have been exposed to and engaged with the social media world, the biggest change in your outlook in life is the idea that people are connected with other people and that you can use social media and the people on social media to get your messages out, to get behavior change programs started. But it just continually characterizes the idea that people relate to each other for lots of different reasons that, by the way, have nothing to do with health. So we've had evidence for this for a number of years. Some of you remember New England Journal of Medicine, 2007, where, again, Christakis and Fowler began talking about how do social networks actually predict the spread of obesity in the Framingham cohort. There's been other evidence looking at how do we use networks to frame opportunities and constraints for change. Why is it that overweight women tend to cluster together? Why is it that overweight men tend to cluster together? And if we understand that, how do we start using that information to create opinion leaders, groups? How do we change the membership of these clusters of people? How do we bridge these groups to groups that don't have so many overweight people in them? How to rewire these groups? How do we expand these groups so that there's more normal weight or people for these overweight people to be exposed to and to learn from? And how do we weave together networks, helping networks, so that people who are trying to lose weight or people who are trying not to gain weight can actually support and reinforce each other rather than being exposed to individual messages? We see the same thing happening in the adolescent obesity world, where again, a little bit more familiar territory for some, schools or household conversations, conversations about family, conversations about neighborhoods, conversations about schools, and conversations about the community are all part of the conversation about how do we address childhood and adolescent obesity and overweight issues. And again, the point is, to go back to the second slide, is we're going from the micro issues to the macro issues. And we need to understand overweight and obesity, and we need to tackle overweight and obesity issues by thinking about those different levels simultaneously, not looking for the needle in the haystack. So I use a lot of marketing principles to do that, as I said at the beginning. And one of the things we have found over the years in research in this area is that there's lots of different components that people can use in nutrition marketing and communication programs, whether it's using consumer research or not, defining priority groups or segmenting them, different kinds of settings, using mass communication campaigns has always been a favorite, using incentives, identifying competitive factors or barriers to why people can't engage in the healthier eating behaviors, using community activation, boards, coalitions to inspire nutrition education programs in the community. And what people always ask me, well, which one works? Which is the one that we should do? And that's the academic question. That's not the real world question, okay? The real world question is what combination of these things is going to be most effective for us. Why do I say that? Remember I mentioned the team nutrition program. And very quickly, the team nutrition program involved public service announcements created by Disney and run by Disney on their channel, a curriculum, cafeteria events, community events, parent participation activities at schools, and parent participation activities at the home. And this was a randomized study that was done in 4 different school districts across the United States involving thousands of 4th graders. And for one semester, kids were exposed to this program. We then did a repeated design and exposed another set of schools to the program again in the fall. And this was the composite results. When we tried to predict behavior outcome using a model of all 7 of these variables, it gave us some good predictive validity for self-reported behavioral outcomes. And I'm not putting up the plate weight studies for those of you who love real actual behavior change. We had plate weight studies to back this up. But what happens with the whole program? Okay, that predicted some outcome. What was the most important predictor of this outcome? If you've got a curriculum running for 8 weeks, 4 hours a week, a lot of nutritionists put their bets on the curriculum's the most important element of this program. And in fact, that turned out not to be true. What turned out to be true is this slide, which showed that as kids recalled the number of channels, the number of elements they participated in, ranging from 0 to 6, you can see the behavior change, or self-reported behavior change, on a scale of 7, usually increased from about 4.3 to 5.1 to 6. It's a very linear increase. Take-home message there is the more different channels kids recalled being exposed to the team nutrition program, the more likely they were to report behavior change. It wasn't a question of either or, and it wasn't a question of which elements were more successful. It's a combination of elements that are most successful. And finally, what are the successful program features? If you're designing a program, you need to select and concentrate on priority groups, not the general population. Again, those programs we find rarely get very much behavior change, maybe move the needle about 5 percentage points at best. Conduct market research to understand consumers, not just kind of feed them the science. Verify the understand and address incentives and costs. Design products, services, and messages that fit people's reality. Test program strategies before implementation. And don't just roll things out because the experts say this is what we think should work, or this is what they should hear, this is what we think will work. Again, don't rely on mass communication campaigns. Increase access to information. Increase opportunities for people to engage in the behaviors is critical. Utilize community-based programs and citizen engagement when you can. Consider policies that include incentives and disincentives for specific dietary and physical activity behaviors, and explore how social networks can be used to influence these and cross these chasms I've identified. So the last two slides here, observation of benchmark criteria. What we've seen in the social marketing and the nutrition education population-based change world is that by using these benchmarks, some of which were just in this previous slides, the fact that they're consumer-oriented and not expert-driven, that we segment the population, we focus on behaviors, we use behavior change theory, insights from consumers, that we manage both the costs and benefits for changing behavior, adjust to competition in the environment, and use all four of the Ps, the product, place, promotion, and price variables. An analysis of data that was in Advances in Nutrition a couple years ago showed that in the early 1990s, no programs that were being published in that time frame used 5 or more of these criteria. But as you can see, by 2009, the majority of programs are starting to use at least 5, if not more, of these benchmarks to talk about programs. So we're seeing that, this idea of communication and marketing is beginning to be diffused and adopted across more of the nutrition community. And finally, just a couple of slides. I'm going to read these because I know in the back you may not be able to read these. Relatively few residents in an intervention neighborhood adopted a new supermarket as their main food store. Again, there are some people who think that when you find a food desert, let's put a grocery store in there, and that will solve the problem. This study by Cummings, Flint, and Matthews found that simply providing new retail outlets is insufficient to encourage the adoption of new stores as residents' main food stores. And not surprisingly, they say complementary methods are necessary. I could have saved them a lot of money doing that study. Concurrent availability of and access to key services and products are crucial to persuade individuals motivated by media messages to act on them. A message is never enough. And that's based on a review of 300 studies. And finally, this last quote from a couple public health people, some people may know Larry Green and some of these others. We conclude from this review of public health nutrition that applied health sciences research would have a much enhanced probability of influencing policy, professional practice, and public responses if it turned the question around from how can we make practice more science-based to how can we make science more practice-based. And that's the take-home message for the thing. And at the end of this, I also have some resources that you can look at, all the references and citations for this presentation as well. And thank you very much for your attention.
Thank you very much, Craig. So we have time for a couple of questions. If somebody has questions from the audience, please go to the mic.
Thanks very much, John St. Peter. I'm with PepsiCo Global R&D. Maybe this is a naive question, but then with your large experience, what do you view the relative impact of the programmatic approaches that you have listed for us and outlined to other social engineering objectives like taxation to drive behavior and consumption? Is there data that demonstrates more direct, monetary approaches have, what's the relative impact, I guess I'm asking from your assessment? Or maybe that's too political a question.
Well, no, it's not political. No, I don't know that anybody has done comparative studies to say which of these is more important. My personal gut response is that, I don't care. That you will need policy change to change some people. Think of those traditionalists or those laggards. And again, the idea that you need to think about how to use policy to incentivize or disincentivize certain behaviors, whether it's food or anything else, I think is part of the equation. So yes, I think policy changes are part of the macro environmental changes, but I don't think that I can say, or there's any evidence to say that a policy change is better than offering a incentive-based community program.
Perfect. So that you kind of touched on where I thought you might go is where do you see issues like or implementation of interventions like taxation on your normal distribution curve with those subgroups? Is it the laggards that we're getting?
It's usually the laggards. I mean, as someone who's also been involved in kind of the public forums, I mean, if you don't have at least 30, 40, 50% of the population supporting that policy, it's real tough to get that stuff passed. So in order to do that, you've had to push yourself up that adoption curve. You know, and what happens with a lot of different policy initiatives, whatever it happens to be, is that people kind of jump the gun and introduce policies long before the population is ready for them, the population which, by the way, pays and elects for the people who decide on those policies as well.
My name is Ron Kleiman. I'm from Boston. Can you tell me how consistently individuals remain in one of these adopter groups? So, for example, if you're an innovator for technology, are you also an innovator when it comes to trying new foods?
Good question, and the answer is no. That you're not. And as a matter of fact, that also gives me a chance to quickly say, you know, there was a conversation going on about, you know, higher income are the people who live by the water versus the people who live inland, and the difference in socioeconomic status. You will find innovators regardless of socioeconomic status. You know, when we go into low-income neighborhoods, we will find curves like this as well. So it's not even necessarily related to that. And someone who's an innovator in technology is not necessarily an innovator in eating behaviors. So you have to be very tailored and targeted about what kinds of behaviors you're talking about in order to really make this work best for you.
That was very, very interesting talk. You were sort of dismissive to science and science facts. And as a scientist,
oh, good, that came across.
I felt threatened by that. Does science matter at all? Could you sell anything?
Does science matter at all to sell anything? Yeah, to that early adopter category, it can make a big difference. But once the diffusion curve starts, the conversation is less about science and more about what are people like me doing, and how does this behavior relate to me, and how is this behavior relevant to me, and is this something I can do in my life easily? It's those 5 questions that I had up there. That's what the conversation is about in real life. When you get beyond that. And I think, you know, we all want to use the science in order to make the best recommendations that we can, but those recommendations for people to actually adopt them need to be couched in their world and in their reality, and that's the key point for that part of the discussion.
Craig, one last question that we have here, Sophia and myself. So, from the perspective, I mean, you work at the, you know, population level with these, you know, with the strategies that you mentioned, but going back to the individual, in clinical interventions for lifestyle change, there is a big problem, which is, you know, the you know, how long an effect lasts. I mean, I think like we've gone relatively far in terms of designing lifestyle interventions for weight loss and all that, but there is a big problem, which is, you know, the effect of those interventions at the individual level with all the science that we have are, in most cases, you know, very short-lasting. It's very hard to sustain behavioral change in the long run. So what can we learn from your discipline to create, you know, sustaining change that we can apply all the way back to the individual level?
Great question. Yeah, and that we talk about sustainability a lot too, because you can launch these big campaigns, and as soon as the funding goes away, you know, a year or two later, you start seeing declining rates of the behaviors as well. So sustainability is a key issue, and that also brings us to thinking more about, well, what are the systemic changes? What can we be putting in place in communities? How can we make access easily for people to do, and something that will remain after the program has disappeared? How can we, you know, again, people talk about policy as a way of saying, how can we implement certain kinds of policies that will help sustain these behaviors after the funding leaves? But again, it's moving up into these macro levels of thinking about what's beyond the individual. How do we plug them into communities of change that will help support them after they walk out of the clinical intervention, out of the clinical office? Because otherwise we're just turning them loose in a very wild world of all kinds of junk science and all kinds of food choices that may not be the ones that they were learning when they were in the clinical intervention. So it's that micro, macro thinking and getting to that macro level thinking and that systems level thinking is what I think will help address long-term sustainability, whether it's for a person who's been in a clinical program or whether it's a person who's just a free living adult in a community where these kinds of things are happening.
Thank you very much. Okay.
Thank you.